This is Robert Sapolsky, and you're listening to Father-Offspring Interviews.
Please note that this episode contains sensitive topics which some listeners may find distressing. Hey everyone, happy holidays, and welcome back to Father-Offspring Interviews. To get us going, Jasper from London asks, what do we know about the causes of Alice in Wonderland syndrome?
Oh, the minutiae that's out there in neurological and behavioral abnormalities. Alice in Wonderland syndrome. Terrific name for two related neurological disorders. One is called micropsia and the other is called macropsia. Seeing things around you of disturbed abnormal sizes. You look over and the utensils and the salt shaker seem gigantic and the chair seems much too little to sit on, and it's a perceptual abnormality. People have noted this in the neurological literature since around 1955 or so, but it turns out that after World War I, there were a number of cases described in individuals who got the great euphemistic problem of missile wounds. Something blew up and destroyed something in their head, and a subset of those individuals would report that objects were the wrong size. Objects were way bigger than they're supposed to be or way smaller. So we get someone who anecdotally reported experiencing this an awful lot, and this could very well have been somehow pharmacologically induced, none other than Lewis Carroll, author of Alice in Wonderland. And then we get flung into the book itself, where at one point Alice finds a cake with a little note there saying, "Eat me," which wisely she does, which makes her suddenly expand enormously in size, and she's hitting her head on the ceiling of the room that she's stuck in. But fortunately, nearby, there's a bottle of something or other to drink, which says, "Drink me." So fool her twice, she drinks that and suddenly shrinks down again. Thus, Alice in Wonderland syndrome. Some of its characteristics: it is not common, big surprise. Most typical age is around 15 when you see it in someone, roughly equal sex ratio. And in terms of how long does this thing last, typical case, the person has this perceptual abnormality for a couple of minutes. But there have been cases where it's lasted hours. There's been cases where it's lasted months and years. So not to be messed with. So of course, the question becomes, what's going on with this? Not surprisingly, the person who has this disorder also has a sense of depersonalization. They feel detached from themselves. They feel as if they're looking at themselves from outside. They're experiencing all this as an observer. There's also derealization, which is a sense of being detached from your surroundings, which makes a whole lot of sense if the salt shaker seems a lot taller than you and the piano you can step on, and no wonder your surroundings feel a little bit suspect. Who does it occur in? All the sorts of usual suspects. Individuals with tumors in a certain part of the brain, stroke damage in a certain part, a vascular abnormality. Most common in adults, people during migraines, certain types of severe migraines, people get micropsic or macropsic distortions. In some other instances, you get some drug-induced versions, and probably most frequent, given age 15 as the typical age, pediatric cases, you see it after kids have caught certain viruses, most commonly Epstein-Barr virus causing encephalitis. All right, so of course we now want to know what's going on in the brain, and surprisingly there's a fair consensus about this, in that you look at brain imaging studies and you look at where there might be something abnormal, you look at where an injury took place in the brain, you look at where a stroke occurred, you look at all these, and there's a commonality, an area called the temporoparietal occipital carrefour. Carrefour, Latin or Greek or something for crossroads, the crossroads of the temporal lobe, which is on the side here, parietal lobe, and occipital lobe, leaving out the one in the front, the frontal lobe. The meeting of those three lobes that form sort of a four corners, except there's not four corners, and it seems to be at the intersection of the meeting of these three different parts of the brain. That's where the abnormalities come in, where you get micropsia or macropsia. So this explains everything, and naturally this explains nothing, because as you begin to think about it, you would guess things look bigger than they should be, they look smaller, that this is just a visual problem, something that's the realm of, in the back of your brain, the occipital cortex. It should just be a disorder of the occipital cortex, some perceptual screw up where relative sizes of things are being distorted. But you begin to get more distortions than that in some of these cases. You get prosapometamorphopsia, which is a case of visual distortion when you perceive faces as wildly distorted, the eyeballs of different sizes and the mouth sagging on one side or other, often called demon face disorder. So that's pretty weird. And along with that, you also get people with zoanthroprosapometamorphopsia. Nailed it on the first try there, where the distortion is people's faces look like animal faces. Okay, so this is more complex than just sizes of stuff that's seeming kind of weird. Faces, the different parts of it are drooping in different directions. Somebody looks like a naked mole rat, but then it gets even more complex because you have something called microsomatoopsia. And of course, its evil twin, macrosomatoopsia, where it's not that things seem bigger or smaller than usual. Your body feels bigger or smaller than usual. And now it's beginning to make more sense. This is not just a problem in your visual cortex back in this occipital lobe. The intersection, this carrefour, this meeting place, crossroads of three of your lobes right in the spot where they meet, you better bet that's going to be a part of the brain that's integrating all sorts of sensory information, all sorts of internal interoceptive information. And suddenly, instead of just things looking weird, a weird size, your body feels an abnormal size. You are getting interoceptive signals from your body that suggest a distortion there. And it can be even broader than that. Then you can have tachynesia, which is you perceive time as speeding up or slowing down. There's auditory distortions that you get with it. So this winds up making a great deal of sense. This is one very integrative little part of the brain there. And no wonder you're getting distortions of stuff you're looking at and stuff you're feeling inside and time perception and sound perception. Very, very odd neurological disorder. And if we had time, I would go into a relative of all these distortions called Zengerle's automatosis. But that will have to wait for some other time.
So, relatedly, perhaps surprisingly so, Nico from Uruguay asks, is there an evolutionary arms race going on between humans and the COVID virus?
So wonderful juxtaposition in that we're still talking about Alice in Wonderland. So, evolution. All sorts of misconceptions about that. We've touched on some of them when it comes to behavior. Animals don't behave for the good of the species. Animals are not driven evolutionarily by survival of the fittest. It's leaving the most copies of your genes in future generations. So all sorts of these misconceptions. And one that is less common, but still very, very distortive, is the notion that you look at a species, current one, extant one that doesn't seem to be going extinct, and the notion that it's some sort of evolutionary plateau. It's hit some sort of point of stasis. It's figured out how to do things. It has evolved to an optimal point, and it's optimal now, and it could just stay that way. A notion that there's an optimal point of evolution for species, and they all hope to achieve it. And if you don't, you go extinct. Now, Obviously, that's not going to be the case if you're in a changing environment, change in weather patterns, change in food availability, habitat degradation. You're going to have a change in selective pressures, and you're going to have a change, thus, in the genetic makeup of a population. It will evolve in a different direction. But even under circumstances where the ecosystem is absolutely constant, where you have this expectation that species that have figured out how to do it right are just going to be statically there on this plateau of optimality, there's always a problem. And this is where this taps into the paranoia that should run through every species out there, which is somewhere out there, there's something or other that would like to eat you, and it's slowly evolving to be better at it. And somewhere out there, there's something you eat, and it's slowly evolving better means of evading you. It's a constant ongoing process. And this is where Alice in Wonderland comes in. She gets grabbed by the wrist by the Red Queen, who starts running with her at a frantic speed, and they stay in the same place. And the Red Queen saying, you have to run faster and faster to stay in the same place. And thus, we have what in the business is called the Red Queen scenario. You get an arms race between a predator and a prey. Predator evolves something new that gives its advantage. The prey comes up the other way, the predator, and they ratchet it up there with new innovations evolutionarily. And this is an arms race, and they're stuck in this forever until one of them goes extinct. The Red Queen scenario, where each of these species has to run faster and faster to stay in place. When they seemingly are at this static moment there, they are actually having to constantly be evolving, means it being more evasive prey or more successful predators. Now, this was pioneered by a guy named Lee Van Valen, University of Chicago, in 1973, who introduced a totally important concept in evolution, coevolution. You see two species evolving, sometimes symbiotically, but in these cases, these Red Queen scenarios, one of them gets better than the other, and the other gets better, and they go back and forth and back and forth. Now, what would be Red Queen scenarios? One would be you have a predator that gets better eyesight. It's evolved more acute eyesight. Evolved not overnight, over the course of millennia, the ones who happen to have the genetic variability for greater visual acuity passed on more copies of their genes. The predators are getting better at spotting the prey. And the prey species individuals who happen to have better camouflage leave more copies of their genes, and you get an arms race there between spotting your prey and camouflaging yourself. Another example of it in plants. Plants are being predated all the time by insects that come and eat their leaves, and this is plants at the losing end of this predator-prey relationship. So what has happened over time? Plants have evolved chemicals, biochemicals that they stick in their leaves that serve no purpose at all for the plant. They're just meant to taste bad, or better yet, to poison some insect that's chomping down on their leaves, things called secondary plant compounds. And plants are full of them. They make your heart beat faster. Do insects have hearts? I'm not sure, but they make your physiology get abnormally faster if the plant contains caffeine, for example, if it contains all sorts of hallucinogenic things, if it contains some compounds that disrupt reproduction. Plants have all of these secondary plant compounds. Hooray, the plants are coming out ahead because they have all these chemicals that will poison predators, insects, and in fact mammals as well, who try to eat them. Mammals, sheep, any sheep farmer, as I was throughout my youth in Brooklyn, any sheep farmer knows you don't let your sheep graze in fields of clover. How come? Because clover contains a biochemical secondary compound, which is an anti-estrogen. If you're a sheep, you eat lots of clover, you stop ovulating. So we see here the plants have gotten ahead of the ants and the other insects and the sheep on this one. And now the ball is in their court to come up with a red queen counter defense there. And what have they done? Lots and lots of species of plant eaters have developed the means to detoxify these toxins in these leaves. So suddenly they're out ahead, or they can take it one step further. Monarch butterflies eat things called milkweed, which has some bad tasting, miserable toxin in it. And not only have the monarchs evolved the means to detoxify this stuff, they've evolved something even fancier. Rather than detoxifying this stuff, they stick it into little packets in their wings so that if some bird bites them, they taste bad. And thus birds learn to avoid monarch butterflies. And you know where we're heading into with this digression. You got viceroy butterflies that have evolved to look like monarchs, so birds will learn to avoid them also. So we got plants are losing the battle to being eaten by bugs, and then the plants gain an advantage with their secondary compounds, and then the bugs figure out how to detoxify them and in fact figure out a way so that they can use it to their advantage. In some other red queen scenario between the butterflies and the birds, you also see this with certain types of cancers that could be triggered by viruses. Virus comes in, transforms a cell begins to be cancerous, which means it's going to start growing out of control. And cells have all sorts of sentinel things to see when this has happened. And one of the reliable things that cells do to protect themselves from becoming cancerous, this cell somewhere inside you that's not just thinking about itself, but thinking about the whole organism, one of the adaptive things that cells that have been invaded by a viral cancer is they activate a family of genes which kill the cell. The cell commits suicide. The cell commits what's called programmed cell death, also known as apoptosis, or apoptosis is a subset of that family of things, where the cell kills itself so the virus can't have it start dividing and spreading and being a metastasizing cancer now. And what have the cancers come up with, the tumor viruses? They have come up with genes coding for proteins which will neutralize the genes that the cell has turned on to commit suicide. So they can just cause it to start dividing and dividing like crazy. And of course, Red Queen again, you see that a number of types of cells have evolved the means to express something which will inhibit the thing that inhibits the pro-apoptotic signaler in the invaded cell. Arms race going on. So all this brings us to this question here of, can we think about COVID and the human response to it? Can we think about it as being an evolutionary arms race? Is there a Red Queen scenario that's playing out? And it is on two different levels. The first one profoundly reflects the uniqueness of humans, the fact that we can make vaccines, that we've come up with them, and even some humans are wise enough to take them. We've come up with vaccines which could be viewed on a certain level as humans evolving a counter to this virus, which is devastating to us. Aha, the ball is in your court, virus. And as we all know from early 2001 or so, what you see is the virus then evolves new strains that can overcome some of these defenses there, that can overcome some of these vaccines. And now you've got an arms race going on there. But even separate of human technology making things like vaccines, there's an intrinsic Red Queen scenario that's been playing out between coronaviruses, COVID being one of them, and humans and all sorts of other animals out there. Okay, so the COVID virus, it famously has this spike protein on the surface, and it just happens to have a perfect conformation for binding to something called the ACE2 receptor, which is found on the surface of lung cells. as well as cells throughout the rest of the body, but first encountering in the lung cells. And by binding to the surface receptor on the surface of these cells, it gets internalized and begins to wreak havoc. So, COVID has evolved the ability to get into host cells by way of binding to this ACE2 receptor. And it turns out that's a common theme. COVID is one of a whole family of these coronaviruses, and all of them have spike proteins that can bind to the ACE2 receptor. So what people are now seeing as they do what are called comparative genomics, looking at gene sequences of all sorts of different species, there's a whole bunch of species out there that can be sickened by coronaviruses, which is to say the virus has the means to bind to the ACE2 receptor, get inside, and off you go. And what you see is all sorts of species that by now have evolved variants of the ACE2 receptor that the spike protein can't bind to. We're seeing the first evidence a virus comes up with something and a counter strategy by the prey that is preyed upon by coronaviruses. And people are beginning to see the first evidence of that in humans. Some rare individuals who have relatively rare variants of the gene for ACE2, producing a receptor with a slightly different conformation or something, which the virus can't get into as well. Are these people who are immune from COVID? No, but it turns out they get much milder cases. So my guess is if COVID became as much of a nightmare as it was multiplied 100-fold, and we're beginning to see significant percentages of the human population being killed by it, we'd be seeing selection going on in this arms race for the people with the versions of the ACE2 receptor gene that are less vulnerable to the COVID virus. Now, implicit in that, note every time we see a version where the virus, where the pathogen is winning over us, they've made the latest innovation, we recognize it. It's a disease. It's antibiotic-resistant bacteria. It's COVID developing new different strains that bypass vaccines and such. We see circumstances where the pathogen has gotten one step ahead. It's much harder for us to see circumstances where we've gotten one step ahead. How come? Because you don't see anything. That's a circumstance where you're avoiding getting this disease. We humans don't get Dutch elm disease, but who knows, at some point the Dutch elm disease fungus is going to evolve some trick for getting into humans, and there you go. That's going to be its own pandemic, and you will have suddenly the pathogen winning in this ongoing arms race, this Red Queen scenario.
To end today's episode, both Yusuf from Nigeria and William from Belgium ask about the recent suicide of Dr. Nolan Williams of Stanford, a psychiatrist who has been a pioneer in depression research, asking about how someone with this much knowledge about psychiatric disease could fall victim to it in this way, and whether depression is common among psychiatrists.
Well, right off the bat, the answers are it's very easy for someone who's knowledgeable about this to nonetheless fall victim to this. And how common are psychiatrists struggling with mental health issues, depression, anxiety, suicidality really often? Okay, what do the studies show? You look at healthcare professionals, doctors, nurses, dentists, veterinarians, they've got 2 to 5-fold higher rates of suicide than the general population. But now just honing in on doctors, and you look at the 20, 30 different specialties out there, and psychiatrists are in the top 3 for risk of suicide. Psychiatrists, general practitioners, and internal medicine people. Less clear, but still strongly in that direction, looking at psychologists, psychotherapists in terms of elevated rates of suicide. Now, one of the things that consistently comes up in all these studies is it is much more common among female psychiatrists and psychologists than male. And what you also see is, along with risk of suicide, high rates of depression. One study, one recent one, shows that at any given point, about 60% of psychiatrists have something resembling a major depressive disorder. About 15% of psychiatrists at some point in their lives are struggling with post-traumatic stress disorder after some trauma with a patient, a loss of a patient, and 15% is the range that you see among combat trauma survivors. So these are really high rates. And of course, the question becomes, why these high levels? And for all sorts of logical reasons. Some of them reflect external factors. One, right off the bat, there's high rates of dissatisfaction these days amongst doctors, having much to do with assembly line, having to crank through a lot of patients, the constant fear and expenditures of malpractice, the med school debts they are typically carrying for years and years afterward. When you look at all of the medical professions, psychiatrists come out around number 20 on the list in terms of income. They're relatively low paid compared to the other subspecialties. They are relatively more burdened by their medical school debts and mortgage worries. So that's one factor. Another factor, and a big one, as an external factor for psychiatrists, is exactly as implicit in these questions. There's a stigma about mental illness. There's a stigma for any mental health professional having trouble with mental illness, and psychiatrists are at the top of the list. They are very hesitant to seek help because there's an expectation, at the very least, if they were good at their business, they should be able to prevent it in themselves. If they live in anything resembling a smaller community, it's mighty hard to find someone who they could go to for help, who's not going to be a professional colleague. You see a lot of stigma built around that. Nolan Williams, psychiatry professor, 43 years old, absolute pioneer, novel techniques for treating depression, some cutting-edge techniques for using what is called deep brain stimulation, being able to do it non-invasively, revolutionary, all of that. And he committed suicide. And his colleagues who were closest to him have no idea why. His wife, the mother of their 2 young children, also a doctor, was willing to very publicly state from the beginning he committed suicide, as reported by the New York Times, as reported by all sorts of other newspapers. Okay, so there's some of these external factors, people's expectation that psychiatrists should not be in need of psychiatric help. What an irony that that's going on. Other factors are predisposing ones, which is to say, who chooses to go in psychiatry? Who chooses to do that rather than being a sports medicine doctor? And what you see is, ideally, there's high levels of empathy in every medical profession. What you see is particularly high levels among psychiatrists. As a general rule, if you are feeling terrible and you want to cry on someone's shoulder, it's going to feel better if you do it on the shoulder of a psychiatrist than an orthopedic surgeon. And you see fairly consistent personality differences. Why this predisposing personality style in people who become psychiatrists? Not every single case, but at higher than expected rates amid the professions. Why? Because you see an awful lot of people are going into psychiatry because they're bringing some of their own personal baggage into it. They grew up surrounded by a loved one struggling with one of these disorders that not only destroys the sufferer, but those around them have struggled themselves with their psychiatric issues. It's not by chance that someone might gravitate towards the subspecialty of people with psychic pain. But the final factor is, probably most importantly, the nature of what you're doing. What you do day in and day out, 50-minute session in and out, is you absorb the pains of people who come to you. You find out all the ways in which life can disappoint people, all the ways things could be unrequited, all the ways in which people can feel sad and lonely and adapt in ways that make it worse. And This is what you spend all your time wallowing in. As one person in the field has said, being a psychiatrist is like sandpapering your soul every single day over and over again. It's a profession where you have signed up to just marinate in the psychic pains of the world around you. And this reminds me of a great young adult novel, The Giver, by Lois Lowry. It's a utopia that is, of course, a dystopia because everything is perfect and it's so conformist that there's not even colors anymore. People see in black and white, and there's one individual locked away, the giver, this sage who is towering over everything, and he's the only person who could remember how things were. He's the only person who could remember colors, which is great, who could remember war, who could remember sadness, who could remember all sorts of terrible things, and it is his burden to hold that for all of society. Everyone gets to have their painless black and white conformity because the giver is the person who takes it on for the whole community. That's what mental health professionals are. So it is a tragic event to occur to someone who all the people I know who worked with him said was a wonderful, caring person, and obviously extremely path-breaking in terms of helping other people suffering. And turns out, big surprise, sometimes there's massive suffering going on silently within the whole time.
That's it for episode 92. I'm Offspring Sapolsky, and thanks for your continued support of science and the beard.